In this presentation, I'll be discussing how technology is used to either deliver or augment psychotherapy. We begin first by defining what is telehealth, and then to discuss which types of telehealth we'll be discussing in this presentation. So telehealth is defined as the distribution of health-related services and information via electronic information and telecommunication technologies. So you can see that it's a very broad umbrella, but there are four pretty well agreed upon types or approaches to telehealth. The ones that we will be focusing on this presentation are mobile apps and synchronous live two-way communication. A lot of people, when they think of telehealth, are actually thinking of the synchronous live two-way communication. They don't really realize that when they use these other approaches, they are also engaging in telehealth. So I'm going to begin by discussing the first two that we won't really be discussing. So I'll just give you a quickie overview of those. We begin first with remote monitoring. Some good examples of remote monitoring are, say, a woman who has been struggling with preterm labor. And previously, this is a woman who might be admitted to the hospital for several weeks to remain on an external fetal monitor to watch for contractions. So now with remote monitoring, she can have some type of monitor on her belly and go about throughout the day, and someone at some external site is watching to see if contractions are occurring or watching for fetal movement. Another good example of that would be, say, a heart failure clinic where patients are given devices such as a blood pressure monitor, a scale, a pulse oximeter, and every morning they're to check these vital signs. These all are reported back to some central monitoring facility, and so the nurse who's there might be looking at it and say, oh, wow, Mrs. George has gained 4 pounds in the last day. Maybe I should call her, see what's going on, make sure she's not having any shortness of breath or anything like that. So those are two examples of remote monitoring. The second way thing that we'll be talking about is store and forward. Many of you have used store and forward and probably don't even realize it. A good example would be x-rays. For example, if you work in a small rural hospital, there might not be a radiologist who's always available and on call. And so sometimes when the x-ray images are then sent to someone who's very far away, and they make their interpretation and report that back to you. So that's store and forward. So it's completely asynchronous, it can be completely asynchronous. In other words, those activities can be taking place at a time and distance separate from each other. Another good example that we use in a clinic that I'm involved with is retinal scan. So you know how challenging it can be to get your diabetic patients to get their annual eye exams. And so they were given a device that does a quick retinal scan, and those images then are sent to, I guess, some ophthalmologist sitting on the beach in Boca Raton who does their evaluation of that retinal scan and sends the report back to you. So those are two examples of store and forward. There aren't a lot of applications for those two types of telehealth technologies in the field of behavioral health. So that's really the extent I'm going to talk to you about them. We're instead going to be focusing on the synchronous live two-way communication and mobile apps. Telepsychiatry is when telehealth is used in the treatment of behavioral health conditions. And we kind of think of it as two different audiences. Who is our audience? As you see here in this picture, this is an interaction between a provider and a patient. So that's one way that it can occur. But the other way that telehealth can be used in behavioral health is it allows two providers to talk to each other. So it might be a psychiatric provider talking to a primary care provider and trying to better integrate behavioral health into primary care facilities. So the psychiatric specialist providing support to the primary care team through telehealth. There are a number of benefits to telepsychiatry, probably none more so that it really opens doors to people who might otherwise not live in a place that has any type of psychiatric services, whether it's marriage counseling or help for their child who has ADHD. There may not be those resources locally. And through telehealth, they can get themselves or their family the care that's needed without having to leave their own community. So again, think of your rural areas that really are very much underserved. We have shortages of healthcare providers in these areas. This is the way many of the people in the rural areas receive their specialty psychiatric care. Certainly reduced travel times. So if you're a person who does need the specialty psychiatric care, autism care, that you don't have to drive to the big city all the time to get that care. Shorter wait times, again, by improving this access locally. Earlier diagnosis and treatment. Again, there are a number of things that can delay entry into the behavioral health services, but through telehealth, we get a little bit of smoother transition. It also helps to build capacity among rural providers. So when you think about it, so say if you're a person who's a family nurse practitioner and you're functioning in a very rural clinic, and you've got a patient who's got a serious and persistent mental illness, and you're just really not sure how to best care for that person, having the ability to connect with a specialist is really helpful to that individual. Helps them to feel less professionally isolated and more confident and competent in caring for that person who might have a behavioral health disorder. And then certainly reduced stigma. We know a lot of people with mental health conditions are reluctant to seek care. They don't want to be seen going into a mental health facility or clinic. And so telehealth kind of breaks down some of those barriers. There are drawbacks to telepsychiatry as well. There can be resistance on both the side of the patient and the provider in terms of integrating telepsychiatry. There are a lot of people who really value that human connection, the ability to establish that rapport, to see a patient, and that really makes them reluctant to want to adopt telepsychiatry. There also can be patient resistance. They don't want to look at somebody on a TV. They want to they feel like they can't get to know them well. There can be other reasons in individuals who have psychiatric conditions in which it might even be inappropriate. A person who's having very significant delusions and hallucinations, and having somebody talk to them through a television really might support these delusions. Also, there can be insurance reimbursement practices. We're lucky in the state of Michigan that we have what's called telehealth parity, which means that services that you provide via telehealth have to be reimbursed at the same rate as a face-to-face visit. That is not always the case in other states. So telehealth visits, and in those cases, telehealth visits have much lower reimbursement rates. So certainly that's a disincentive to adopt telepsychiatry or telehealth. It does take a good bit of planning to implement this. What kinds of internet capacities do my patients have? What kind of broadband support do we have? What kind of training is needed? What telehealth platform has the greatest degree of privacy? So there's a lot of planning that goes into it. And if you don't have a champion or someone who has that specialized knowledge and expertise, the plan is going to be, the implementation of this is going to be far less successful. Then finally, we have technology adoption resistance. There's a lot of people, whether they're patients or providers, who they say, this is just a new technology. I am not interested in learning. I've survived for all of my 70 years without it, and I'm not about to learn this new stuff now. And those are the same types of resistance and pushback we see with implementation and adoption of electronic health records. So I'm sure some of you have either experienced it or witnessed it. And then, again, education and training, I think that's a little bit redundant. But technology infrastructure is a huge barrier. When you think about our communities that are in these rural areas who may not have broadband access, those are the places where you have this very spotty coverage, and nothing's worse than holding a telehealth session and not being able to hear every other word that the patient is hearing, or if you're talking with your psychiatrist colleague, not being able to hear him, see him, whatever. When the video freezes or something like that. So those are real challenges. And then there's also legal developments. Like how are you protecting the patient information? As it goes out there into the atmosphere. How is that being protected? And what is your duty to warn a person? So what acknowledgments need to be made in terms of using this telehealth? So there are a number of legal issues that are of concern as well. So for individuals who may be considering adopting telepsychiatry, these are the things that you've got to kind of keep in mind. First of all, the patient. Unless the patient is actually in a clinic setting, then some of these may not be issues. But if the patient's actually in a home setting, do they even have the appropriate device? You can deliver telepsychiatry via a smartphone, but they might only have a flip phone. Do they have a tablet, a laptop, a desktop computer? What kind of device is it that they have? And do they have an adequate connection? We've kind of talked about that a little bit. If they've got cellular service, is it internet? And do they know how to use the technology? Some folks may have internet service, but they don't know how to connect an iPad to the Wi-Fi or something of that nature, being able to use that part of technology. And do they have a place where they can engage in telepsychiatry that's private? Again, thinking of a patient in their own home and engaging with a therapist, and you've got their family members walking in and out. Maybe they're in a living room or something like that. So, do they have a place that's private? On the provider side, in terms of considering launching telepsychiatry, do you have the IT support to problem shoot issues that are inevitably going to come up? Do you have the support on the billing side? Because you may miss a number of billing opportunities if you don't have someone who's knowledgeable about telehealth. And a good example of that is that there is something called an originating fee, and that a facility can charge a fee. The clinic can charge a fee if they're engaging in telehealth, and that's on top of the telehealth visit itself, that you're actually bringing in money for the facility to carry out the telehealth. And so if a person wasn't knowledgeable about that's money left on the table with every telehealth or telepsychiatry encounter. And then finally, scheduling support, making sure that the person who's doing scheduling has given you ample time to have the patient get logged on, to you get logged on, and that the visit isn't rushed, because there's going to be technology glitches, technology failures, and if your schedule is too cramped, everybody's going to get frustrated, okay? So let's talk about some of the reimbursement issues, the things that you need to keep in mind if you ever want to get paid for telehealth or telepsychiatry. The first thing is, where can telehealth originate from? And the originating site is, where is the patient? Okay, where's the patient at the time the service is rendered? Okay, that's the originating site, wherever the patient is. So the answer to that is, it must be a health professional shortage area. And there's a way to look that up online to find out if your area is considered a health professional shortage area. If you're not considered if you're not considered a health professional shortage area, you're not going to be paid. Okay, so it has to be a health professional shortage area plus one of these things. The patient has to be in an office of a physician or practitioner, hospital, critical access hospital, rural health clinic, FQHC, hospital-based or renal dialysis, skilled nursing facilities, community mental health, or tribal health centers. So that's where the patient has to be, one of those things. There is an exception, a recent exception in 2019, that says that for those who are undergoing substance use treatment, that they don't have to be in a health professional shortage area, and the home is an acceptable originating site. Again, that's just for those who have substance use disorders. The next question is, who can provide telehealth? So here we have a list of individuals who are called distant site practitioners. These are the ones who can furnish and get payment for covered telehealth services within their scope of practice. And again, this is coming from the federal level. This is coming from Medicare and Medicaid. And however, so again, at a federal level, there are 50 different state Medicare, Medicaid offices who then look at these rules, and they may decide to be more stringent than that. And a good example here is that in the state of Michigan, clinical social workers may not furnish or get paid for telehealth services. So, but in just about every other state, they can. So again, these are federal guidelines coming from the U.S. government. The states are allowed to interpret them more strictly. They cannot interpret them more loosely. So it's really important that you know what do the states allow. Now, what I'm providing here is an overview of Medicare and Medicaid, which are public insurers. There are any number of private insurance, Aetna, Blue Cross Blue Shield, whatnot. So, and they can decide their own standards for who gets to furnish and get paid for telehealth services. They may even offer and there's been a lot of interest in telehealth among public insurers, among private insurers, that they offer, hey, you can call 24/7 to this and you'll get to talk right to a primary care provider, whether you're having a cold or you think it's flu or a urinary tract infection. And we've seen many commercials about this on television, parents of a new baby wondering, does this poop look okay? Those are good examples of commercial private insurers really pushing the envelope with telehealth, and they're really kind of setting the stage. The U.S. government is well behind this. So we have much more rigid rules here in terms of Medicare and Medicaid reimbursement. Okay, I'm again continuing to go in the same vein of Medicare, Medicaid, other requirements. It has to be interactive audio and video telecommunication, meaning you can't just pick up the phone, talk to the patient, and call it a telehealth visit. It has to have both the audio and the video component. It has to also be real-time communication. It can't be a recorded message. I mean, even if it is video, they can see you, they can hear you, and it's delivered to them. If there's no opportunity for there to be a two-way conversation, then it's not considered telehealth. So it has to be real-time communication. And then also in terms of the distant site, where is the provider? That provider can be anywhere as long as they're licensed in that state. And we'll get to that later. So it doesn't mean that a provider must be sitting in a clinic. The patient has to be, okay? And again, go back to those originating sites that I talked about on an earlier slide. But the provider can be wherever. So in terms of telehealth, there are some important rules that you also need to be aware of in terms of your ability to prescribe. So first of all, and these are just basic rules, that you already have to have an existing provider-patient relationship, meaning you can't hang out your shingle and say, okay, I'm going to do telehealth now and start doing prescriptions if there's no existing provider-patient relationship. Okay, so there has to be a provider-patient relationship established. You have to be practicing within the scope of your practice, and again, that varies by state. Michigan is considered to be a fairly restrictive state in terms of prescribing, as compared to other states that have full independent practice for nurse practitioners. If you're going to be prescribing controlled substances, there are special rules. There's a federal rule called the Ryan-Haidt Act. What happened with Ryan-Haidt, a young man who was able to procure a boatload of opioids from an online clinic who had never met him and sent him a bunch of opioids, and he overdosed and died. And as a consequence, there are special rules. In particular, they must have an in-person visit with that prescriber prior to prescribing controlled substances. So, for example, if I have a child in my practice who has ADHD and they're on Ritalin, which is a controlled substance, if the first time I meet that person has to be a face-to-face visit. Subsequent visits we could do telehealth, but the initial visit must be an in-person visit. So if necessary, we have to be able to provide the patient with referral to local health services, including emergency services. So if I'm doing telehealth and something comes up that gives me great cause for concern, like talking about suicide, I have to be able to give them immediate referral to emergency services. And I also have to be able to provide follow-up care. So if someone's coming into my clinic virtually and I don't know who they are, or don't have a good contact information, I can't deliver for telehealth or telepsychiatry. Okay, there has to be an ability for me to follow up with that person or refer them if needed. There are a few other cautions that you need to keep in mind is that you need to be using a secure portal, that you can't be using Skype or FaceTime. In most cases, email is not secure either, depending on the type of email you have. Sometimes it's encrypted. And you have to find HIPAA-approved ways to connect, and there's going to be a slide coming up that talks about what are some of those platforms. Use caution when taking pictures. I've seen providers do this a lot. If there's an unusual lesion or something of that nature, and they want to document it either in the patient's record or send that image to a dermatologist, that image is still on your cell phone if that's what you use to take the picture. And so practices really should have a dedicated clinic camera and some way to discard images once they've been properly attached to the patient record. So just really cautious about taking pictures, knowing that those devices are secure. Obtaining consent is necessary when you do telehealth. Verbal is okay, but you do have to document it. And if the patient resides outside of Michigan, you have to have licensure in that state. So that's really important. Like say that you are licensed as an advanced practice nurse and someone calls into your telehealth line who is in Ohio, that unless you have an Ohio license, you better not be rendering care to that individual. So the information that I presented is baseline information pre-COVID pandemic, all right? So now we're going to talk briefly about some changes that resulted because of this public health emergency. So the public health emergency was declared in January of 2020, and it's going to end by the head of the Department of Health and Human Services. And he, his last name is Azar, A-Z-A-R, once he determines that this public health emergency is over, then 30 days later, all of these loosening of the regulations will disappear, and we're going to go back to the same old system that I just described, okay? So currently, we're in a public health emergency, and I'm going to talk now about some of those loosening of regulations. So, originating site. Remember, previously I said, and that's where the patient is. The originating site is where the patient is. And I had listed that it had to be in a HPSA, and it had to be at a clinic, at a doctor office, at a FQHC. But that is no longer. The location can be at the patient's home. So the patient can be at home, and we can deliver care there. The next thing is telehealth providers. In the state of Michigan, remember they were excluded. Michigan has lifted that restriction, and now social workers can also provide and be reimbursed for telehealth. The audio-visual requirements. Remember, I had said that it has to be audio plus visual, and they have now eliminated that as well, that it can be audio only. It can be telephone. That's the state of Michigan as well, okay? There are other states that still require both. The federal government has said, okay, it doesn't have to be both audio and visual. It's up to each state to interpret how they want to use that. The state of Michigan said, okay, we're fine with telephone. And remember, we talked about the Ryan-Haidt Act, that it had to be an initial in-person visit if they're going to be receiving controlled substances. That has been waived. The first visit does not need to be in person. It can be telehealth. Initially, they said, okay, it can be telehealth, but it's got to be audio-visual. And then about a month later, they said, never mind, it can just be telephone only. Okay, so those are some of the things, some of the ways that telehealth services have been expanded during COVID-19. In terms of telehealth platforms, remember I had said no Skype, no FaceTime. Okay, so there's been some loosening of that, but it's important that you recognize the limitations of this loosening. So back in like mid-March, the Office of Civil Rights said, hey, we're not going to go after people who might violate HIPAA. We know that as long as it's in good faith and you're making every effort to protect that privacy, we're not going to go after you for HIPAA violations during this public health emergency. And it said, okay, then you may use any non-public facing remote communication product. And they did use, as examples, FaceTime and Skype. You can use this to provide telehealth services during this emergency, okay? And it doesn't have to be related to those people who you think have COVID. It can be whatever. So about 3 days later, they came out with like, oh, okay, there's a clarification. This loosening up of these HIPAA compliance platforms does not apply to 42 CFR Part 2. That particular federal rule pertains to privacies that we offer those who are in substance use treatment. So they backtracked on that piece, that if an individual that you are caring for is receiving substance use treatment, that you don't have the flexibility to use any non-public facing remote communication product. You don't get that opportunity. It must be HIPAA compliant. In the next 2 slides, we're going to be looking at a few platforms that are HIPAA compliant and those that aren't. So that's just really important to know. Substance use treatment does not get that broad latitude. So when you're evaluating different telehealth platforms, there's really one thing that you need to be looking for, and it's called a Business Associate Agreement, BAA. A business associate agreement is a written contract between the covered entity, meaning you, your clinic, and a business associate, and it is required by law for HIPAA compliance to ensure both security and privacy. So if you're looking into a company and they're not willing to enter into a BAA or a business associate agreement, then that product is not considered to be HIPAA compliant because it doesn't have that. There's no assurance like, okay, I'm going to protect your privacy and security by doing this. These are the layers of protection that we put on our product. So here what we're looking at, all of these here, as you can see in the first column, are willing to enter into a business associate agreement. The product that I use is called Doxy.me, and the business associate agreement is very simple. It's already pre-made. You just check a box that you acknowledge it, print it off for your records, and boom, it's done. So it's very seamless. The reason we chose Doxy.me is because it does allow for group visits. I'm part of an interprofessional clinic, and so there are times when I need to meet with my patient along with the occupational therapist or the dietitian or the social worker, or I might have a student with me that day. And so it's important that it's not just me and the patient. I had to purchase a product that would allow for those group visits, and it was reasonably priced, and there are free versions of it. So and I could also do like a monthly thing. I don't know when this is going to end. I don't know when I'm going to go back to seeing my patients face to face. And so I don't want to enter into a year-long contract, but I am willing to do something month by month. So there are a variety of things that you can kind of look at and determine whether or not it meets your needs or not. So these are all okay to use for in any settings, including substance use disorder. So these are things that are okay to use in most settings, but not with substance use disorder because, again, they're not considered HIPAA compliant because they don't offer the BAA. Again, if you were a provider who's going to treat someone's rash or their chicken pox or their cold, these are fine. But when you're dealing with substance use disorder, none of these are acceptable. And then here I'm just going to reiterate things that have not changed. Okay, people think, okay, it's all free for all, you can do whatever, but these are things that have not changed. You have to be licensed in the state where the patient is located. And so during this COVID, I'm at my home in Idaho. I'm still continuing to provide services for my patients in the state of Michigan, and I am licensed in the state of Michigan, and I can do so. You have to follow all state and federal laws, get the proper informed consent. Again, a verbal consent is appropriate. I do have a sample informed consent in Canvas under resources. Have a plan for psychiatric and medical emergencies, because if someone's threatening suicide, I need to know where I need to send them next. And then in terms of the documentation on the medical record, then we have to, make sure that we're complying with law, regulations, and guidelines. During this pandemic, there are a number of states. This is a very abbreviated list, but the link there it will show you more. But there are a number of states who said, oh, the heck with the licensure, that if we get into a pickle, we'll take anybody. So Connecticut, let me just use New York. As you know, there were many providers, nurses, doctors, respiratory therapists who lived in other parts of the country and have moved immediately to New York to help with their crisis. They did not have to seek licensure in the state of New York, which would have been a very costly process, a time-consuming process, and there was an emergency. And so basically the state of New York said, listen, we'll take all comers. As long as you are licensed in a state and don't have any judgments against you, whatever, then we will take you during this public health emergency. And so I just wanted to let you know of those that you do have to double check, if you're planning on doing something like that, and also make sure that your own malpractice insurance covers both telehealth and you working in another state. So just some general guidance. What are some of our best practice in telehealth? Really just before you engage in this and before you meet with every patient, making sure, okay, is my equipment okay? Do I have a decent internet connection? Do I have a telehealth platform that's easy to use? I love Doxy.me. That's the one I use because they come in to this waiting room. So there's this general waiting room. They can't see anybody else, right? They don't know what other patients might be there to see some of my colleagues, but they get a chance to see my waiting room. And I have things posted in my waiting room. For example, I might have a cute cartoon or a joke of some sort. I might have some of the latest information from the governor. I might have a posting of some online support groups through Peer 360, which is one of our local things. So they're sitting in my waiting room and I get to bombard them with whatever propaganda I want to. So, and I try to make it very relevant and health related and motivating and uplifting. So making sure the telehealth platform is easy to navigate. Eliminate interruptions. I mean, we've all seen instances recently where someone's doing a broadcast and then something crazy weird happens in the background, and one of the toddlers comes in, or the dog dumps over something on the coffee table. So just making sure there's no interruptions, managing your background in terms of, you might want to remove personal pictures, just not having it something super distracting. Managing or adjusting your camera, looking at the patient. That's sometimes a little tricky. And, I always let my patients know that. And I'll say, I just want to let you know I'll be looking down frequently because I'm just kind of taking notes as we're talking because I don't want to forget anything after our conversation. So if you see me looking down, then I'm just jotting down a couple of notes. The other thing I do is sometimes when I'm talking to my patients, I have to look at a different screen because they may be asking me something about a prescription. And I may say, oh yeah, last time I gave you 2 refills or something like that. But sometimes I have to look at another screen, and I always tell them, I'm going to look away for just a minute because I've got to look at my other screen. Because they often interpret that differently. When they see you looking at other things, they think you're distracted and not engaged. So I always give my patients that heads up. I do normally speak a little bit slower because that allows for time delays, etc. I try not to have any papers near my microphone that I'm going to be rustling and things like that. And I know who I can connect with if I get into trouble with my technology. So I think those are some kind of best practices or etiquette that you can keep in mind when you're doing telehealth and telepsychiatry and therapy sessions using technology. We talked briefly about documentation. These are the requirements of documentation. So say that you have a particular way of documenting when you're seeing a patient face to face. These are some new things that you would need to add to that note in order to be reimbursed. So you need to document the originating site, okay, where is the patient, okay, the distant site, where is the provider? And so I'll usually write patient's home or patient's car. I have a lot of patients actually who go into their car to talk to me because it's the only place they can get some privacy. Who's present? Okay, is it just the patient, or is the patient and spouse, or is it me and a student? So who's present? Have they given consent? Again, this can be verbal, it can be written. And then finally documenting for phone visits might be a little bit different, because often when I have a face-to-face, a video conference, there's a lot of additional things that I can report, in terms of their expression or maybe psychomotor agitation or something like that. I can document those things because I can see them. Of course, on a telephone, I can't, so, there are some differences in the way we end up documenting things when it's telephone only. Speaking of telephone only, often the last thing you want to do is sometimes have your patient get your phone number. So how do you go about doing that? How do you call someone to initiate a therapy session without them having your number? And so there's really two different ways of doing that. You can block your number. You just do *67 and then dial the number as usual. And so what the patient would see on the other end is blocked call. And so often you'll need to let them know, hey, I'm going to call you at 2:00. Your appointment's at 2. But in case you're screening calls, you might notice it's going to say blocked call, and that's me. So you can do it that way, or you can download a mobile app called Doximity Dialer. It's free, and you can put in there whatever you want. You can just say, you can write your name in there, so that when they receive your call, they will see the number and see your name. Or maybe you want to put the clinic there. One of the providers that I work with thought he was funny, and he wrote the White House on it, so it'll say the number and the White House. So you can put whatever you want so that the patient will see the name, a randomly generated number, and then who it is that you are. Okay. And they can also use that number to call back to your clinic. So you could put your clinic number in there if you wanted. Okay, so those are just ways that you can call a person without them then having your number. So up until this point, we really talked a lot about, how you can do a live, synchronous, two-way audio conversation or audio and visual conversation, and assuming that both of you were on the other end. However, there are types of therapy that maybe don't even need a therapist, right? So these are what we call computer-based therapy. And what we typically see with computer-based therapy is they are usually used as an adjunct to face-to-face. An example might be you have a therapist talking to you and doing some cognitive behavioral therapy in a session and say, okay, now there's a special website that I want you to go to, and here's some homework I'm going to assign you. And so they used the computer-based therapy to really augment what they're doing in session. So that's one use of it. But the other, there are standalone products that, that if a person's having depression, there's a place called Mood Gym, MOODGYM, altogether, Mood Gym. And there's no therapist involved. The patient self-paces themselves through these cognitive behavioral sessions. There is no therapist involved at all. So what does the research say about this? And surprisingly, they've found that things that are computer-based only, standalone, that they're standalone, there's no therapist involved, that many of the outcomes, such as improved depression scores or decreased anxiety or whatever the outcome is they're trying to measure, the outcomes across the board are actually very similar to the outcomes experienced with a therapist. So that's kind of interesting science that I think is going to be important, is going to move us forward and thinking of different things. So why would a person want to do that? Well, think about it. If there's a special program that can help you with your depression or help you with your anxiety. No therapist needed, just log on. You can log on whenever. Well, then if I live in a rural area or a real urban area, it doesn't matter, somewhere where there's very few therapists, or if I call and say, oh, it's going to be a 4-month wait, or your insurance doesn't cover it, then this is an avenue for me to get that access. It also decreases stigma, that nobody knows who I am. I'm anonymous. And it also helps those individuals who might not otherwise seek help. And I think about my individuals who have drug addictions. And a lot of times, we know only 1 in 10 individuals who has a drug addiction will seek help. And when you ask those other 9, well, how come you're not seeking help? They're like, there's many reasons. One of them is stigma. But a lot of them say, I think I can do this on my own. I really don't need help. And so this might be a good opportunity to at least get them started on that path to help, and then decide that, maybe they do want to see a therapist or something. And they also can have access 24/7. I was involved with a product that did a computer-based cognitive behavioral therapy for new moms who are struggling with postpartum depression. They loved it because it's like, having a baby, a newborn, is so unpredictable. I don't know when this baby's going to sleep. I don't know when I'm going to sleep. But I like the opportunity that if it's in the middle of the night and I'm already awake anyway, that I can go ahead and engage with some computer-based therapy. So there are a lot of advantages, potential advantages. There are some drawbacks, which we'll be talking about in a few minutes too. But I think this is something that we need to think about and consider as either an adjunct or even a substitute. And I know a lot of therapists don't like to hear that, but when you're talking about patients who desperately need some treatment and no one is available, then this is an absolutely acceptable alternative in most cases. There are reasons when it wouldn't be appropriate, someone who's severely suicidal and actually needs hospitalization. So I'm not saying it's perfect for every situation. It isn't, but it's something to consider. This is an example of something that we're getting ready to deploy in some of our rural clinics. It's called CBT for CBT, so computer-based treatment for cognitive behavioral therapy. And it kind of walks the person, it talks to them about what is this, a CBT formulation. Okay, now here's some videos of how it's done and how you might use this. And here's some little learning exercises. And finally, okay, now test your knowledge about it. So that's one example of cognitive behavioral therapy delivered completely online via computer or via mobile app. Here's that same product, some vignettes and testimonials of individuals, how they've overcome certain things. This version happens to be about substance use treatment because that's my area of specialty, so I'm always interested in what kinds of products are available. Now we're switching gears slightly, and we're going to be talking about virtual reality and how this is a technology that can enhance therapy or find a different way of delivering therapy to individuals. And we'll use a couple of different examples. There are a variety of applications of how virtual reality goggles could potentially be used. So certainly mindfulness, relaxation, stress reduction, those are really important skills that can be used across the board because they do reduce anxiety, they do reduce tension. And so what virtual reality goggles do is they really immerse that patient into kind of this calm and natural environment where they can develop and hone those skills. And if that's used in a therapy session and we have the ability to combine that with biofeedback sensors, for example, heart rate, respiratory rate, the amount of sweat on the palms. So if we've got biofeedback sensors, the nurse practitioner or the therapist really can help the patient recognize those physiologic responses to the stress and anxiety. And that empowers them then to initiate these relaxation techniques and to reduce the distress. So certainly this has a number of potential applications in mental health across the board. Then we have instances of where we use virtual reality as an adjunct to exposure therapy for people who experience phobias. And so in this example here is for someone who has a fear of flying. And so here this person goes through several scenarios that actually begin with when they're at home and packing the bag, because a lot of people have anticipation anxiety. But then they have the taxi ride to the airport. Then there they are in the kind of the boarding area, and they're in this virtual reality. They also hear, overhead announcements, flight such and such is boarding now. And, so they get to really immerse themselves into that environment. And then they walk down the jetway, and here they are approaching the plane. And then there's the takeoff, so they get to see what's happening as they're looking out the window. And then we see the interior of the plane. And all of these environments are adjustable by the therapist. This actually has our goggles that we have at SVSU. And the therapist can adjust things. So for example, during takeoff, they can have it be the middle of the night, or they could have it be a rainstorm. Or once inside the cockpit, that they could make turbulence occur. Now mind you, they're not going to actually feel turbulence if they're sitting in a chair, but it gives the visual appearance of turbulence. And so this is the therapist then is introducing scary things to this person in a very graded response. And now I just want to point out that exposure therapy, like most other therapies that you will be learning about, requires additional training. It is not anything that any of you should feel comfortable jumping into. It requires additional training. And learning how to use the virtual reality goggles to augment exposure therapy also requires additional training, right? So this is one application of the use of virtual reality in exposure treatment. Here's another application. And so if you're thinking about, and again, my area of expertise is addictions. And so people who are struggling with addictions really are no different than those others who have chronic disease conditions. And they have, as we will learn and as we recognize, they have periods of relapse and remissions. So relapses in addictions, they often occur when the person who's struggling with that addiction encounters a person or a place that they associate with their addictions. So in the case of a person who has an alcohol use disorder, a bar such as this might be a very high-risk situation that has that potential to trigger a relapse. So virtual reality therapy exposes the patients to simulated situations that would normally trigger anxiety or cravings, but it does it in a safe and controlled environment. So for example, the patient can practice refusal skills when, let's say there's a friendly bartender offering them a happy hour drink, or if they're pressured by an inebriated friend to, hey, just have another. So they actually get to practice these skills when they're with the therapist. And that there's been a number of research studies that have suggested that this type of role-playing, virtual reality role-playing, reduces the likelihood of a relapse when presented with this situation. But the research really is evolving. So of course, the thing that we worry about is, could this trigger a relapse? Okay, I've just, through this virtual environment, brought them into the very place that really triggers these cravings. And, what if after a therapy session, they head to the first bar because that was so enticing to them? So that's why you have to be very careful and very well trained in these types of therapy. And so that's a really important piece. The use of biofeedback is really important, and I know I touched on it when we were talking about relaxation, but biofeedback is important to these other things as well, because again, when you as the provider can see when the heart rate's going up, when they're getting sweatier on the palms, and then you can back them down from that. Okay, I noticed when that inebriated person came up to you, or that pretty girl was hitting on you, that your heart rate started going up, your palms were sweaty, what was happening there, and just kind of exploring that. So the use of biosensors really enhances the virtual reality therapy. So now we're going to segue into mobile apps. Again, this is one way that we can harness technology as a tool to help individuals who have mental health disorders. So it's pretty easy to just go into an app store and just typing in mental health or anxiety or depression. And you see a number of self-help tools that are available for those who have various mental health disorders. MindShift is an example. I've used this before, but it helps with anxiety management, guided support, helps them to do some deep breathing exercises. So there's a number of mobile apps that are very similar. I'm not endorsing this one, but again, you can kind of check some of these out. Most of them are free, and decide if it's something that you would like to recommend to your patient or not. So this happens to be a product that I use in my clinic. It's called HS. And again, the patients I care for are in recovery. They happen to be older adult patients. So it's the only geriatric focused substance use treatment facility in the entire state of Michigan. And so we onboard patients with this at their first visit. No, I don't know if it's their first visit, maybe the second or third, but we onboard this onto their smartphone at the first visit, And there's a number of things that are included. There's some peer support things where they can connect with other patients if they choose to do so. It gives them reminders about their medications, reminders about their appointments. And also we help them to set up motivational tools and a plan. Some people like to really customize and tailor the motivational messages. For example, people have different reasons for wanting to stay sober, and it might be their grandkids. So in terms of their motivational tools, they might upload some pictures of their grandkids, or a recent video of their grandkids blowing out the birthday candles, or a ballet performance, whatever. But we help them to customize the things that keep them motivated, and it also enables them to connect with their counselor, their peer specialist, their recovery coach if needed. So again, it's a very all-encompassing type of mobile app. This mobile app also allows the patient, if they choose to do so, to enter into the system using GPS some high-risk location alerts. So it's kind of like to geofence certain areas that they consider to be high-risk location. And so, for instance, it might be the corner bar. That might be where they always went to when they were ready to unwind and left 6 hours later totally inebriated. It might also be the place where they bought their cocaine. Okay, so they know their high risk areas, and they're allowed to put a geofence perimeter around it. So then if they've got their phone in their pocket, when they approach these locations, a warning button is triggered to alert the patient. And that, in addition to triggering that alert, it also might send them personalized and tailored motivational messages, and also providing an opportunity for the patient to reach out to the counselor if needed. Now, again, one of the things that I've found that I have to reassure patients on is like, okay, I don't know where you're going. I can't track you. I don't have any idea if you've approached your high risk locations. That's totally for you and for you alone, because people do see that as a potential invasion of privacy. So we've had a couple of interesting outcomes with the patients who have used this particular mobile app. Again, I've mentioned it's called HS. It's also pretty pricey. It costs about $18,000 a year for a total of 500 patients. Not all of those are our geriatric patients, but our entire clinic. So it's not cheap. However, we are able to successfully bill this through Medicare and Medicaid as a virtual visit. So when we use this with our patient, each virtual visit gets reimbursed $8 or $9. So it does end up paying for itself over time. So I just wanted to let you know a little bit about it. And again, I'm not advocating for it. I just wanted to share with you how different mobile apps can be used to support people who are in therapy, and how an individual who's providing therapy, well, I'll get to that in a minute, but from the patient experience, again, we have older adults, and we weren't sure how this was going to fly with our older adults, but and we have not had as robust of uptake among our older adult population as the younger folks. So those who are the younger folks, no problem. They navigate around it, they use it. But our older population, many of them don't feel comfortable with the technology, and many of them surprisingly had older phones like flip phones. But for those who did use it, very high satisfaction. The things that they liked the most were the peer-to-peer support, the motivational messages and videos, the appointment reminders, and that ability to connect with their counselor if they needed to. And so we're doing some research related to this right now. Like so those who adopted this mobile app, are there fewer relapses? Is there longer retention in services? Are there no-show rates improved? Because this product is marketed as a relapse prevention app. So I want to know, does it really work? Is it preventing relapse? On the provider side, well, we've had some mixed reviews because a lot of providers, when we initially rolled it out, we said, okay, everybody's going to use it. And people don't always like to be told that they have to use something. So some people readily adopted it and seem to really love it. Others are continuing to push back on it. However, the thing that they seem to really like is that they're able to, one of the components of this is that every day, the patient takes a survey. Do you think you can make it through today? Okay. Without having your drug or alcohol or whatever. Can you make it through the day? If they say, yeah, that's it. Okay, if they say no, then they get those motivational messages, an opportunity to connect with their counselor, etc. The other thing they do is they take a weekly survey that talks about, over the past week, how were things with your cravings? How were things with your relationships? How was your physical health? So they take a brief survey, and then that then allows the therapist to kind of look at trends over time. Like, okay, here you had a relapse, and I see that was the time when you mentioned that your spirituality was very low, or that your relationship with your boyfriend was really crumbling. So now we know these things are associated with relapses for you. So how can we build your strength in these different areas? So again, it helps to predict and prevent relapse. It can be used as a patient teaching tool and allow those therapists to really tailor counseling. Like, okay, you've reported all these protective factors in the past, and now suddenly you're saying that you don't have the support from your family. Well, what's happening in your family? So it really opens a door into other aspects of the patient's life that you may not have known about previously and been able to link them with that particular relapse. So overall, for the providers who've adopted it and use it, they really like it. Again, there's still some resistance among others. But again, that's just an example of how different mobile apps can be used to support the therapy that is being delivered in the office setting, or others that can be self-directed and help the patient manage their own symptoms, such as anxiety, depression, the types of tools that teach you things like slow, deep breathing and positive messaging and things like that.